Hey team, good morning. Justin Dunaway here with the Institute of Clinical Excellence. I am lead faculty in our Persistent Pain Comprehensive Management course, which last cohort of the year started this week. So if you have any interest at all in jumping in that, I think tomorrow is the final day to register. We also have, and I'm also lead faculty for our Total Spine Thrust Manipulation course, which is kind of what we're going to discuss today. So today's main topic is cervical thrust manipulation and risk of dissection stroke. And the reason I want to talk about this is I would say every 8 to 12 months, I get a handful of emails or a handful of tags in these really heated conversations on Twitter or X now or whatever it is, and in Instagram. And it all tends to center around a person or a case that recently had a severe catastrophic event. And somewhere in their recent history, they indexed care with chiropractor. And in those threads, in those conversations, in those articles, there tends to be a lot of emotion and a lot of misinformation. And the request is that I go in and sort that out. And I'm never going to do that. It doesn't make any sense. Those spaces are very emotionally charged. And it makes sense, right? Because all of those spaces come from a place of grief, where we're analyzing a specific human that had a severe catastrophic either death or life-changing event that has massive impact on them, their family, their providers, everybody that knew that person or knows somebody that had a similar situation. And the last thing anybody in that space wants while they're grieving is for somebody to swoop in and say, well, you know, Whedon 2019, blah, 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 blah. Like, that's not going to move the needle on any biases in any direction. And it's, I mean, at the end of the day, it's probably a bit cruel, right? So it doesn't make any sense to dump a bunch of logic in a very emotionally charged space. But that conversation does need to happen. So that's what today is for. My request is that regardless of which side of this debate you land on, you shed all those biases or as much as you can, and you listen to this next little bit with an open mind. We're gonna strip away the emotion. We're not gonna talk about an individual. We're not gonna talk about a specific case, but we are gonna talk about this issue. And we're gonna talk a bit about some of the research. And then really where I wanna go is the path forward, because I do believe that there's a very specific path forward that does reduce the risk of dissection stroke for all the patients that we come in contact with. So if I had a little bit more space on the title screen, the actual title of this podcast would be "Not Performing Cervical Manipulation Does Not Reduce Your patient's risk of dissection stroke, but the belief that it does might actually increase that risk." Now, that might get the hackles up on some of you, and I'm going to make the case for that here in a minute, but just kind of bear with me. Again, let's open mind through this next little bit. So the two pieces of the argument that you tend to hear are this. One, when you look at the whole of the literature, manipulation is either just placebo or not effective or have minimal effectiveness or is not more effective than anything else, and it comes with inherent risk. So from a risk-benefit ratio, it doesn't make sense. It should be eliminated from practice and reduce risk and save humans. So we're going to talk a little bit about that research. Let's start with the efficacy. Much like many of our interventional research in conservative management, the research is all over the map on this space, from quality, from bias to and outcomes. It's all over the place. I think, at least again, I'm a bit biased. I teach this stuff. I've used this as a main part of my practice for like 15 years. To me, the evidence says that at least in the short term, manipulation is a very powerful intervention, especially when coupled with exercise and active interventions. When you compare it to mobilization, when you compare it to other techniques, it tends to, depending on who you read and who the authors are, it tends to be all over the map. In the long term, it doesn't seem to have a massive effect in the long term compared to anything else. But when you look at any of our other research in the long term, it all kind of tends to land in the same spot. And that has a lot more to do with how we research than anything. But I'm not here to debate the efficacy research. What I really want to talk about is the risk research. And it's a lot more clear in this space from a population prevalence perspective. So just spontaneous dissections. What you see is the population prevalence of internal carotid artery dissection is about 2.5 people for every 100,000 people will experience a internal carotid artery dissection. And for a vertebral artery dissection, you're looking at about 1 in every 100,000. Now, when you look at manipulation, when you look at dissection strokes following manipulation in the research, you'll see it's anywhere between same day as the manipulation up to 30 days past the manipulation. They kind of lump it into this bucket. Your prevalence of dissection stroke, either kind, following a manipulation, again, same day up to 30 days, is about 1 in 100,000 to 1 in 6 million. So when you compare that to the population prevalence, at the worst end, at the most prevalent end, it matches population prevalence. So you can't really draw any conclusions from that at all. It's happening at the same rate in both cohorts. And then on the other end, 1 in 6 million, it seems like it's happening significantly less in that space. And then we have other research, right? So that's just population prevalence research. Then you've got other research. You've got retrospective trials. It's two of the more famous ones, where Cassidy looking at vertebral artery strokes and Koslov looking at internal carotid artery dissection strokes. And what they did is they went back, they found people that had these strokes, and they went back and looked at their cases, and they looked at who had been to a chiropractor, who had been to a chiropractor and a physician, and they compared that to population just age-matched controls going to a physician. And what they found is there was no increased risk. There was no difference in the amount of strokes happening in chiropractic visits versus primary care visits, right? So again, their conclusion was that there was no increased risk for stroke following manipulation. And then you've got prospective trials. And probably the best trials here are from a Whedon et al. Research group. And they've got 2 massive trials where they look at the Medicare population. And they take over 1 million cases of humans in the Medicare population that have head and neck pain, that indexed care, that either went to a chiropractor or a physician, but not both. And they follow them to see if anybody has strokes. And again, there is no increased number of strokes between the chiropractors or primary care. And the conclusion of all these trials is the same. Manipulation doesn't seem like a likely cause of stroke. Okay. So that gives you the first part. Not manipulating does not reduce your risk, right? Because the risk doesn't live in that. It lives in something else. But I want to put that in context for a second. Let's step back and think about that. So when you think about exercise as an intervention, or just exercising on your own, there is risk in that. Did you know that one person out of every 1,500 people per year will have a severe adverse event from exercise, from exertional activity? Heart attack, stroke, death. Or the other stat that you can pull out of this is for 1 out of every 1.5 million episodes of exertional activity will end in a severe adverse event. So when you compare that to the risk of manipulation, exercise seems a fair amount more dangerous. But when I say this next line out loud, it's not going to make any sense. Because this risk of exercise is so great, to reduce my risk of severe adverse event in my patients, I'm not going to prescribe exercise. That doesn't make any sense. That does not reduce their risk of catastrophic cardiovascular event. What does? How do I reduce that risk? By understanding the risk factors of cardiovascular events, by understanding my patient's history, by understanding their comorbid status, their medications, by understanding signs and symptoms of cardiovascular problems, by being able to monitor vitals, understanding what resting vitals look like, understand what exercising vitals look like, understand what that should look like in this patient's status. And the better I understand that, the more of an expert I am in cardiovascular health and exercise, the better I am at reducing humans' risk of having that event during exercise. Nobody's saying, ooh, let's not exercise. They're saying, okay, cool, let's understand this better. So how does that relate to manipulation? Not manipulating does not reduce your risk, but how does believing that increase your risk? And that comes from this. Understand that if you believe that manipulation is the problem, if you believe that manipulating is causing the strokes, even at this stage of the game, it takes you off the hook. There's no incentive. If you believe this, if you believe manipulation is the problem, there's no incentive for the clinician that doesn't manipulate to become an expert at cerebral vascular dissection, pathology, risk, signs and symptoms, mitigation. Just don't understand at that level. There's no need to, because I don't manipulate, so that's never going to happen. So why would I become an expert in this space? The point of this conversation, team, is not to take manipulation, or not to take clinicians that it is to take manipulation off the hook. It is not to take clinicians that manipulate off the hook. It's to put everybody on the hook. It's to put the humans, any person at any level of care, whether conservative management or medical management, who has contact, who cares for humans with head and or neck pain, on the hook for understanding vascular pathology to the level necessary to pull this patient out of the crowd. So how do we do that? What is the path forward? The path forward looks like this. It's about stopping this debate. It's about stopping blaming the technique and start learning about the pathology, start learning about the humans, what they look like, what their risk factors are when they walk in the door with an unapparent dissection stroke, with an unapparent arterial damage in process, and being able to pull that human out of the crowd. So how do we do that? I think that instead of me going through all of this stuff, because again, I've got biases, you've got biases, depending on which side of the line you're on. There are 3 articles to start with that I think really build a foundational knowledge that you need if you're going to be treating humans with head and neck pain. The first one is from the International Federation of Orthopedic Manual Therapists. It's called the International Framework for the Examination for the Cervical Region for Potential of Vascular Pathologies of the Neck Prior to Musculoskeletal Intervention. Big mouthful, but this is a beautiful article it's an expert panel from all over the world that is just that this is where we're at with the evidence, and this is what we do with it. The next article, Cervical Artery Dissection, an overview and implications for manipulative therapy practice, from Lucy Thomas. This is an excellent article, short read, that dissects debunks a lot of the myths around vertebral artery pathologies and internal carotid artery pathologies, tells you what these patients look like, and tell you what to do if you suspect a dissection in progress. And then the third article, a systems-based approach to the assessment of cervical spine prior to manual therapy, from Taylor and Carey. They do a really beautiful job of splitting internal carotid artery and vertebral artery pathology out and showing you exactly what the ischemic and pre-ischemic signs, symptoms, and pain patterns for each of those pathologies would look like. These 3 articles together give you a really solid foundational understanding of what these patients look like. Now, 2 things. Thing number 1 is if you head over to Dr. Dunaway DPT, my Instagram page, if you go into my bio, in the link tree, I've put links to the full articles for each of these 3. So I want you all to read these. Number 2, when you look at the back half of the titles of these, for prior to musculoskeletal intervention, for manipulative therapy practice, prior to manual therapy, you can ignore those parts. Because again, the titles still tend to lean us down the path of the intervention. It's not the intervention. And when you read the articles, they're not interventional either. These articles aren't for manipulative therapists or for physical therapists or whoever. These articles are for all of us, whether you're conservative management or medical management, who treat humans with head and or neck pain. So head over to my link tree thing there and check out these articles. Okay, so at the end of the day, team, this argument tends to get emotional because we tend to focus on a specific person, a specific case, and that makes sense, right? In the moment, we need to pull away from that and start to think about this logically. At the end of the day, whether you do manipulation, whether you don't manipulate, whether you think it's beneficial, whether you hate it, whether you think nobody should do it, doesn't matter. At the end of the day, none of us care about manipulation. What we care about is people. What we care about is the safety and well-being of the humans in our care. And we all care about that. This debate about manipulation, about the technique, this constant focus on villainizing a specific technique distracts us all from the true thing, the differential diagnosis. It distracts us all from being able to dive in deep into the literature to really understand what these humans that are susceptible for severe catastrophic event look like, sound like, what their risk factors are, how they show up in the clinic. And if we can get away from that debate and we can dive deep into really strengthening our understanding of this, that is the path forward. That is the thing that reduces risk in these patients. So my ask is simple. Anybody listening to this podcast, if you haven't, or even if you have, it's a beautiful refresher. Pause what you're doing, hop into my link, download those 3 articles, knock those out in the next week. Read them with an open mind. And at the end of the day, I don't care whether it shifts your belief on manipulation at all. What I really want is for that information to live in everybody's toolbox so that when the patient walks in the door, and this is so rare, many of us will never see this in our entire career, but when the patient walks in the door with the risk factors, with the signs, with the symptoms that are indicative of an unapparent arterial pathology, we now have the tools to pull that patient out of the crowd and get them in the place they need to be. So check those articles out. Let it change your practice. If you have questions about that, drop that in the chat. At the end of the day, team, I just want to thank you all for listening. This is an important topic. Have an awesome day.